All right. Thank you so much, Sydney. Good morning, everybody. I want to say thank you for coming this morning to our lightning talk for master's thesis research. My name is Kayleigh Blaney. I work here in the Dean's office at the NYU School of Global Public Health. And I would first like to give a warm welcome to all of our speakers. First, we'll have Dr. Mary Armstrong-Hough. Then we'll hear from Dr. Eric Klinenberg. And then we will also hear, lastly, from Dr. Pat Satterstrom. In this session, each of the professors will present for about 10 minutes on their research, and they're going to conclude with some information on data sets at the end for you that might be relevant to your thesis work. Feel free to drop your questions in the chat. We will be monitoring the chat, and we can get those questions to the professors at the end of their talks. Sydney, who's helping us out technically today, will filter through and pull out those questions, and we'll answer those at the Q&A at the end. We will also be sharing resources at the end on data sets and information on the upcoming thesis talks as well, if you're interested in those. So without further talking from me, I would like to pass it over to our wonderful faculty who will introduce themselves, share some information about their area of practice as well as their research. And first, we're going to start off with Dr. Mary Armstrong-Hough.
Hi, everybody. I recognize a couple names of people joining. So for some of you, this work is going to be familiar, and feel free to chime in at the end with any clarifications or questions. I'm just going to take a second to share my PowerPoint. Can I get a thumbs up, Kayleigh, if you can see that? Perfect. Great. So my name is Mary Armstrong-Hough. I'm a newly minted associate professor. I just got promoted in the departments of social and behavioral sciences and epidemiology here at NYU School of Global Public Health. And I'm the director of AIR Lab, which stands for Advancing in Respiratory Equity. And what we do is design and evaluate interventions to improve outcomes for serious acute respiratory diseases. And we tend to focus on tuberculosis. I was cross-trained first as a sociologist. I got my PhD in sociology. And then I did my postdoctoral training in applied biostatistics and then in epidemiology of microbial diseases. So a lot of our work historically has focused on improving outcomes and reducing transmission of tuberculosis in sub-Saharan Africa and Southeast Asia. But in recent years, with the advent of COVID, we've also moved to doing a lot of work on reducing disparities in survival of respiratory failure. And that's actually what I'm going to talk about today, because we have some cool data sources associated with that project. But if you're interested, please do go and look at our lab website. That's airresearch.org. We have about 16 active members, 3 PhD students, 2 full-time staff, a couple physician fellows. But we've got about 10 MPH students. So take a look, and if you're interested in any of our work that's based in Uganda, Kenya, or Vietnam, feel free to send me an email about it. What I want to focus on today, though, is some of our US-based research. In 2020, I had only ever worked on global research, actually. I saw myself as a tuberculosis epidemiologist, and then COVID hit. And because I'm a TB epidemiologist, I work with a lot of pulmonologists, lung doctors, who work in critical care. And a lot of them started saying to me at the beginning, we are seeing our ICUs full of a more diverse population than we're ever seen before. And we have this gut feeling that outcomes are different by race and ethnicity. And so that sort of is what shifted me into this respiratory failure work, to try to start thinking about what the mechanisms might be for differential outcomes of respiratory failure in different American populations. So first, a little bit of a background. Respiratory failure is actually quite common. It's deadly and it's disabling. So 750,000 Americans die each year of respiratory failure. If you have the most severe form of respiratory failure, which is acute respiratory distress syndrome, ARDS, your chances of dying in the ICU, are upwards of 35%. So it's quite a deadly condition. But most people do survive. And we have 2.5 million annual survivors of respiratory failure, who experience poor physical function and quality of life for at least 5 years after discharge. And I say at least 5 years after discharge because we don't actually know. We don't have longer longitudinal studies to show this. And that's one of the things that my team is trying to change. But what really got us passionate about this work was an insight back in 2020 that Hispanic patients were less likely to survive respiratory failure once they're put on a mechanical ventilator. So Hispanic patients are about twice as likely to die within 90 days once they experience respiratory failure. And we have known this for 17 years. We have multiple large cohort studies that show us that this is true, but no one has ever identified any mechanisms for this disparity. This goes counter to most of the trends for Latino Americans. They're actually more likely to survive almost everything else. So there's something that is happening here that is special. And in particular, we think it is something that is happening in the delivery of care in the hospital. Because like I said, this is a statistic that applies to people who are mechanically ventilated. So once they're in the hospital, once they experience respiratory failure, and once we control for all of these comorbidities, all of these other things that they bring with them into the hospital, we're still seeing that they're twice as likely to die once they experience respiratory failure. So our team hypothesized that Hispanic patients may be more likely to be exposed to certain care processes that are not best practices. And in particular, we thought that they might be more likely to be exposed to deep sedation. When you experience respiratory failure, if you are intubated, you're put on a mechanical ventilator, it's not a fun experience. So most people will be sedated in some way for it. The recommendations are that those sedation targets be what are called light sedation targets. So you'll be a little bit loopy, you'll be a little bit calm, but you're not going to be comatose. Deep sedation targets, on the other hand, are more similar to what you may have seen on TV when you think about a coma. Those are people who are made unavailable by their level of sedation. Deep sedation is not good for you. Sometimes it's necessary, but it's always harmful. Deep sedation is associated with longer time spent on the ventilator. It is associated with more days spent in the ICU. It's associated with brain dysfunction, including delirium, and it's associated with much worse long-term functional outcomes. So these are what we call activities of daily life. Your ability 3 months later, after you get out of the hospital, to be able to go to the grocery store, to call a friend on the telephone, to dress yourself. These instrumental activities of daily living. And most importantly, we've known for 20 years or so that sedation worsens 6-month mortality. So people who are deeply sedated, once we control for all the other characteristics of their clinical picture and their care, they are substantially more likely to die. So it's not good for you. All right, so we went ahead, we found data from 48 ICUs around the country. What we did was we worked with NHLBI to identify patients who had been enrolled in the control arm of a large trial for neuromuscular blockade. This is actually the only trial in all of critical care that had a sufficient number of Latino patients in it for us to do this analysis, which tells you something about who is getting enrolled in NIH-funded clinical trials for respiratory failure. We measured deep sedation for these patients over the first 5 days, every day. And we use multi-level mixed effects models to evaluate the associations between race and ethnicity and deep sedation, accounting for a whole bunch of different things. First of all, of course, the clinical picture for the patients, their age, their sex, their body mass index, and then we used a time-varying sequential organ failure assessment score that was drawn from about 30 different domains. And we also accounted for hospital-level effects and patient-level clustering in these outcomes. And we found 2 things that were really interesting. The first is that Hispanic patients were more likely to be at hospitals that really like to deeply sedate their patients. So Hispanic patients are attending hospitals that are just more likely to deeply sedate everyone. But even once we accounted for those big differences in the sedation happiness of the hospital, we found that Hispanic patients had about 5 times the odds of being deeply sedated compared to non-Hispanic white patients. So what we're finding is that Hispanic patients are deeply sedated more often, and they're deeply sedated for longer. This all translates into about a 19 percentage point increase in probability of receiving deep sedation for your average patient. So the takeaways from this are that Hispanic patients are at higher risk of exposure to this non-evidence-based practice that we know is associated with bad outcomes. And there's a need to assess how care is being delivered to Hispanic patients in the US, why these differences in care exist, and develop interventions to make sure that people are receiving equitable care in ICUs. So we ended up getting awarded an R01. It's a large multi-year grant from the NIH in order to examine these questions. We're about 2 years into that right now. Our team are quite diverse. We've got sociologists, a lot of intensivists, epidemiologists, healthcare delivery researchers. And we've hypothesized that specific care processes, including but not limited to deep sedation, produce disparities in survival and function for Hispanic patients. And our scientific premise is that inequities in respiratory failure are created by interlocking and reinforcing mechanisms that operate across multiple levels: the patient, the clinician, and the ICU organization. And so what we've tried to do is design a study that is going to address all of these levels. So I'm not going to talk too much through what's known and what's not known here, but you can go to precipicestudy.org and read more about our specific hypotheses. What I really want to focus on telling you today are what data we're collecting, what we're analyzing, and what, if you're a student who's interested in this work, what opportunities there might be for you. So our study has 3 aims. The first was to evaluate trajectories of long-term function for Hispanic and non-Hispanic survivors of respiratory failure. So that's getting at, okay, if Hispanic patients are much more likely to receive this non-best practice that's associated with bad long-term outcomes, what happens to folks who survive? And can we learn about the environments that they were in the hospital, how that affects their long-term functional outcomes, but also think about the environments that they return to when they're discharged from the hospital, and how things like their access to walkable neighborhoods, to being able to get up and down stairs in their own homes, how that might affect long-term outcomes. The second aim is to characterize care delivery by for respiratory failure by ethnicity. We are working with 10 ICUs around the country. We're collecting a bunch of qualitative data. We do site visits. I just got back from one. I'm extremely underslept right now. We actually we saturate all shifts in the ICUs. And we're doing that all around the country right now. And that means that we're also collecting interviews and survey data from ICU clinicians. Finally, we're refining and piloting an intervention that is meant to target inequitable care delivery, to use some of these structured assessments, which already exist in critical care practice, and sort of do implementation work to make sure that they are applied across all patients, so that patients get equal care. So here's what's relevant to you. We've got some qualitative data. We have interview data with Latinx families of critically ill patients in the New York area. We are in the process of collecting interview and survey data from critical care nurses, intensivists, pulmonologists, ICU directors, and respiratory therapists at 10 ICUs around the country. And then importantly, our quantitative data. For this study, we have put together 40 million patient observations from over 1,000 hospitals around the country. This represents every single acute respiratory failure hospitalization and every single COVID-related hospitalization from 2017 to 2021 at Premier Healthcare Alliance hospitals. So this is a really unique data set. We have follow-up outpatient events, we have patient demographic data, diagnostic codes, procedure codes, and disposition at discharge. What that means is, were they alive or dead at discharge? Were they discharged to a skilled nursing facility, home, etc.? There's a lot of potential here. The one thing that I do want to say is that working with these data is going to require you to be really, really prepared. You need human subjects research certification, the clinical practice training. You have to get onto our multi-center single IRB. You need very, very strong coding skills in RN's data and the ability to work in a Unix secure research data environment that's a command line environment. So this is not for everybody, but If you are that kind of student, and we have at least one person who's already going to do her thesis with these data, it's an incredibly exciting data set. And I think I'm out of time. Is that right, Kayleigh?
Yeah, we can circle back because Eric needs to leave at 9:30. So we'll go to Eric and then we can circle back to you, Mary, before we start questions.
I'm done. Yep.
Awesome. Thank you so much. We will next move to Dr. Eric Klinenberg. Thanks, Eric.
Okay, terrific. I unfortunately am in a room just below construction that started about the second we began. So I don't know how much you can hear it, but I'm really hoping it's not as bad for you as it is for me. It feels like someone's drilling in my ear. Good morning. Welcome to NYU for all the students here. My name's Eric Klinenberg. I am a professor of sociology. I also have appointments in the Wagner School of Public Policy and in media, cultural communications. And I have some relationship to your school, but I don't even know what it is. I'm also the director of an institute at NYU called the Institute for Public Knowledge. And I'm sending a link to all of you in the chat here right now, in case you're curious about it. We are a kind of large provostial level institute that includes faculty and students from all the different schools in the university, from health to Langone to the law school and the engineering school, arts and sciences. We work on big team-based projects on a range of topics. I have a strong interest in cities and climate change. We also work on social infrastructure, on democracy, on race and inequality, on AI, a lot of projects and a lot of public programs. And regardless of what you're interested in, I'd encourage you to check out what we do and feel free to come and participate. What I want to do today in just about 10 minutes is tell you a little something about where I was when I started graduate school many years ago and the problem I was thinking about, and tell you how it's extended into today's world and created research opportunities for a whole range of people, including you. So when I started graduate school, it was the fall of 1995. And that summer, there had been a big heat wave in the city I grew up in, Chicago. And I was really curious about what happened there. Something like 739 people died in just a couple of days. And I was concerned about what happened, but I also just wanted to understand, why did the heat, which seemed like a fairly innocuous thing in 1995, suddenly kill so many people? And who did it kill? And where did they live? And why did some people in some places seem like they were especially vulnerable? And I did this thing that a lot of social scientists do, and sociologists who study cities, especially when they're interested in phenomena like this. I drew a map, and I wanted to see like which neighborhoods in Chicago were most affected. And when I first drew the map, what I saw was, the most uninteresting, obvious thing you could imagine. It was that the neighborhoods in Chicago that were hardest hit by the heat wave were these very poor, racially segregated, quite vulnerable neighborhoods on the south side of Chicago and the west side of Chicago, places that have big health problems and big equity issues on a daily basis. And it's no surprise to anybody that they were the most vulnerable during the heat wave. If that was the end of my research, I would not be sitting here right now because I would not have a career in social science. That's just such an obvious finding that it's politically important, right? It's when there's an inequality in a health event, it's important politically to note that and to make sure everyone registers it. It's politically important to ask, if we know that that's likely to happen, why don't we do more to protect certain people in certain places, right? And we should raise alarm bells if we're not doing that. We're not trying to redress the problem. But scientifically speaking, it's not very interesting to find that the most vulnerable communities in daily life are most vulnerable in an extreme event, because it's what you would expect. Does that make sense? It's just what you expect. But then something interesting happened. I decided to kind of turn the microscope a little bit tighter. And I looked more closely at what was happening in neighborhoods within the west side and within the south sides of Chicago. And I saw these variations that were incredibly interesting. And I noticed, for instance, that you had these sets of neighborhoods that were demographically almost identical. Like the people who lived in them were almost the same in terms of the racial composition or in terms of the age or education level or class. But some neighborhoods had really high death rates from the heat, and others that were separated by just one street, right? Same demographic profile, separated by just one street, had really low heat wave mortality. And that became the basis for comparative research. I wanted to go more closely into the neighborhoods and see what was really driving the disparity. And I observed a bunch of things, but the core finding that I think is relevant for all of us now is that the neighborhoods that had really high death rates were places that weren't just poor and segregated. They also looked depleted, abandoned. They had lost tremendous numbers of people. They had lost a lot of jobs. They had lost employers. They had a lot of empty lots. They had abandoned buildings. The condition of what I've come to call the social infrastructure was really poor. And what that meant is that people who lived in those neighborhoods, especially older people and more frail people, as an adaptation strategy, had just kind of spent more time in their apartments or in their homes, less time in public settings because the gathering places weren't that nice or inviting. The sidewalks were broken. The stoops weren't good places to sit. There weren't great branch libraries and diners and air-conditioned grocery stores. And people just got in their cars and socialized when they could, or if they got older and more frail, they spent a lot of time indoors. On the contrary, the neighborhoods that had the lowest death rates, that were in many cases literally across the street from these high death rate places, tended to have a far more intact and vibrant social infrastructure. They hadn't lost population at the same rate. They had little pocket parks. They had community organizations and branch libraries and places where you could go and kind of hang out on a daily basis. And what that meant is if you were 80 years old and you lived in that neighborhood and you were the kind of person who routinely would spend time outdoors on your stoop, sitting on a bench in a coffee shop, at a library, and that weather turned to 105 degrees and suddenly you weren't outside, your neighbors noticed and they knocked on your door. And it actually wasn't that it wasn't a cultural thing. It wasn't that like the people in the neighborhoods with strong infrastructure cared more about their neighbors than people in the neighborhood with the weaker social infrastructure. It's just that the social infrastructure of the area encouraged a kind of street level social life, a daily social life that proves to be protective. And it was really fascinating. I saw disparities of 1 to 10 in terms of the mortality rates, comparing the areas that had strong and weak social infrastructure. Then I zoomed out and I noticed something even more profound, which is that those effects weren't just there for the heat wave. They were there for a whole range of conditions. And in fact, if you looked at the neighborhoods with strong social infrastructure compared to the ones with weaker social infrastructure, the life expectancy, literally going across the street, was a difference of 5 years. And that is a massive difference. Social infrastructure at the time was not something that social scientists had on their radar. It's not one of those things that you measure with census data or with standard data sets that we use to look at neighborhood health. And so part of this research for me was exploratory concept building. It came from ethnographic research, from close observations, and it involved an effort to try to throw into the mix a factor, like a social structure, a condition that matters for daily life, that matters for health, matters for death, but that we don't think about routinely. And I tell you that story because a lot of my work in the subsequent decades has involved trying to understand how physical places in cities and communities shape our capacity to engage each other and to live healthy lives. I have a big project right now that brings together two streams of my research. One is about cities and climate change, and anyone here who's interested in how climate change is becoming a major public health issue that's affecting our capacity to live well, to deal with big shocks and crises, should definitely come to the IPK or reach out to me. and ask about opportunities to get involved. We do a lot of work on climate change vulnerability and the capacity of cities to deal with changing conditions here on Earth. IPK led a massive federal program, a multi-billion-dollar program called Rebuild by Design that we put together after Hurricane Sandy in 2012, and that's involved literally building new infrastructures, massive projects around the region affected by Sandy. That ranges from a big new project on the Lower East Side called the Lower East Side Coastal Resilience Project, which is all along the river, to project to put oysters and other natural infrastructure into the breakwaters around Staten Island to reduce storm surge and protect people and their property. We also at IPK are just starting now another very big project that comes from a federal grant to investigate social infrastructure more generally around New York, in New York City and beyond, to assess the state of social infrastructure, places like parks and playgrounds and libraries and athletic fields, to understand how they function, what work they do, to what extent they bridge people across groups, and to what extent they bond people within a group, to what extent they promote inequality and better life chances, and what they could be doing better. We want to assess the state of social infrastructure in a number of different communities and try to line up a bunch of projects that could be developed with federal resources that are there for infrastructure investments. So you just heard from Maria about a project on understanding care and health as it comes together in explicit care settings like hospitals. That's incredibly important work. And the work that we do at IPK is about social determinants and spatial determinants in our cities and communities that also play a big impact on our health and help to determine who lives and who dies. So unfortunately, I've got to run, but I'm very easy to find. I sent you a link to the IPK, and you can find me on the Sociology Department website as well. Be happy to have conversations with people interested in these topics, or even to potentially get you involved in some of our research projects if you're interested. So thanks very much, and I wish you the best.
Thank you, Dr. Klinenberg. All right, and last but certainly not least, we have Dr. Satterstrom.
Thank you. It's nice to join you. I also think I have no affiliation to your group, but happy to talk to you about my research. Pat Satterstrom at NYU Wagner, the School of Public Service. My training is a little bit different than I think most folks that you interact with. I have a degree in organizational psychology, undergrad from Harvard, and then my training was at Harvard Business School in organizational behavior, so things to do with management. And what I'm really interested in is often within and cross organizational issues. So the processes that help teams. So I look a lot at primary care teams, teams in hospitals, often teams that have process improvement work, care innovation work. And my questions are always about how do we get people who are often overlooked and not included, frontline staff, front desk staff, medical assistants, patients, their families, how do we get them involved in the innovation process in healthcare organizations such that the organizations improve, folks get a sense that they are involved in the process and their outcomes improve, and they also provide avenues for career development for folks who are in these organizations. So in particular, I'm interested in diverse teams, in dynamic hierarchy, and in issues of voice. So in terms of diverse teams, I've been working in this area for a while, sometimes in healthcare, but not quite always. So for example, one of my earlier studies was looking at creativity, and there were a lot of mixed findings in terms of, diverse teams sometimes outperform teams that weren't diverse. And by diverse, we mean racially and ethnically diverse teams. And sometimes they do outperform. So why is that? Why do they outperform sometimes, but not outperform other times? So in this study, we found that by bringing people into the lab and always having a Caucasian raised in the United States, and having someone from East Asia, from Japan, from South Korea, from China, and running them through these experimental studies. Some of them were quite creative and some of them weren't, and they were all kind of demographically similar. So what kind of explains some of those differences? And what we found was that it was their exposure to other cultures. So in measuring their past experience living abroad, the movies and shows they consumed, the food they ate, the kind of analogies that they were able to make, we actually saw that their processes in speaking and communicating and building on each other's ideas were actually quite different. And so some of my work is experimental and some of my work is longitudinal ethnographic. So in terms of my more ethnographic work, I go into organizations often for years at a time and collect data on folks doing their day-to-day work, and also meeting in teams to do innovation work in their organizations. And some of my work is quite theoretical in the management space. So trying to create new frameworks, new theories for understanding how different people, so if someone brings up an idea, how others around them can actually support that idea to get implemented. And that's led to a bunch of different publications in the healthcare space about how do you do that with nurses, how do you do that with patients, how do you overcome bureaucratic voids and walls to be able to do that in large hospital settings, in primary care. And recently, some of my work is on kind of how do we create more dynamic teams. So and a lot of the healthcare organizations that I work with, they bring people together from all parts of their clinics, including patients often, and they say, oh, everyone's going to be able to contribute and work together to create improvements. And time after time, I probably followed 24 teams, and it rarely happens. The hierarchy comes into play. Folks who are worried about productivity, effectiveness, and efficiency, and who are more senior take over the work. Everybody feels perhaps more comfortable with each other at the end of it, but the kind of goals that were set out weren't met. And then there's always some exceptional clinics that do actually change drastically. And so then we document what it takes in terms of skill building, in terms of changing processes, in terms of changing identity, in terms of lowering individual and team risk for folks who don't often have a voice to gain a voice over time and create change in their organizations. And then there's a number of different studies that I have around healthcare teams. I think perhaps one of my more interesting pieces of work right now that's about to be submitted is on the patient double bind, when clinics bring in patients to try to be more responsive to their needs and to their ideas and to their experiences. And what we've been finding is that what actually happens is that patients whose ideas are quite different from everybody else either get excluded or exit the teams, or they become like the team members, and their ideas that are divergent from everybody else don't come up as much anymore. And so what we see is that, you're seeking outside ideas, but you're creating insiders as you're doing it. And everybody is actually kind of okay with the situation, except for when you follow people over time and see that patient projects become staff projects, become organizational projects. And at the end of the day, patients don't necessarily benefit as much as they might have initially if patients were actually able to kind of stand on their own in these projects. So we give ideas for how that might happen. And so because I don't know how much ethnographic work you do in your training, I just wanted to give you a sense of one of our recent projects. Oftentimes, so my funding and my structure of work, I think, is probably different from other folks. So my work gets completely supported by the university. So I'm never under large grants, and some of my co-authors are, some other aren't. I work with a lot of folks at business schools and schools of public health. And so what we often do is we just, as faculty, we spend a lot of time in the field with our graduate students and our research assistants. And so, for example, in this paper, we focused on 2 teams. We just did a lot of close observation. So 65 meetings, a bunch of interviews, a bunch of artifacts, and tried to understand why some teams were able to create change and what structures were supporting them. Since we have a lot of research in the innovation space about what it takes for teams to be successful, but that research is really not applicable to a lot of healthcare settings because folks have so little experience in doing that. If you're trained as a nurse, if you're trained as a PA, if you're trained as a medical assistant, even if you're trained as a doctor attending, you don't necessarily have a lot of this training. So what does it take to get you up to speed and able to actually make substantial changes on top of your day-to-day work of seeing patients? And so a lot of it is going to interviews, using transcript data, using artifact data, thinking about the themes that are affecting some teams and another, doing a lot of comparative work, looking at, what is this a case of, inducing, going back to the research, and then doing a lot of micro level coding. We use MaxQDA. We do this as a team. And then, in our work, we talk about deductive research, which is often perhaps survey research, experimental research, inductive research that comes kind of out of the interviews and the observations, but also abductive research, which is kind of trying to create concepts and theory around what we're seeing. And so it's a really iterative process. And because we have so many qualitative data points, we're able to kind of quantify them and see when things are happening at different points, and be able to kind of see cycles, not just kind of practices. And, over the time, we've kind of acquired a lot of qualitative data sets that we're still trying to figure out, how LLM models, how AI could help us ask new or interesting questions. I'm not exactly sure how you could work with us yet, but we do have data. We're working with PhD students at Stanford. My RAs are master students and undergrads at NYU and Columbia. We asked lots of questions that I think might be of interest to some of you, especially those of you who are maybe more organizationally inclined. But I'm happy to have conversations to see if there's anything that we can carve out for you or anything that I can support. So if I can be helpful, let me know. Otherwise, hopefully now you know that there exists this type of work at the university, and that I teach courses on management and healthcare organizations, on building effective teams, and other things of that nature if they're interesting to you.
All right. Thank you so much, Dr. Satterstrom. We do have a few questions in the chat, so we'll start with, I want to ask how you make your study more scientifically important. For example, if I am interested in vulnerability and the result I find is obvious, like Dr. Klinenberg said, how can I dive deeper? Is this too general to ask?
I can jump into that, and then maybe Dr. Satterstrom can chime in. I'm actually going to share a slide that I kind of skipped over because I think that it's useful for tackling this question. This is the what's known versus what's not known slide. I think that in Dr. Klinenberg's example, he had more time than you have in a master's thesis, right? Like he got to do this incredibly influential longitudinal ethnographic study of a city that has been heavily studied in ethnographies in sociology, and you have 6 months. So I think that for a master's thesis, what's really important is to articulate a research gap that you can fill. And that is what can make a study, a short-term, smaller study, scientifically interesting, informative, and hopefully useful. So in order to articulate that research gap, first you have to figure out what's known. And so you see on the left the example from our study, what we already knew. So we knew that incidence of respiratory failure for this population was increasing. We already knew that Hispanic patients were twice as likely to die from respiratory failure. And we knew that there was overexposure to this pretty poor practice. But on the right is what then we didn't know. And so it wouldn't be useful to do another study that would reestablish any of the things on the left. They're all horrifying, but each of them actually then is associated with a next question. And for me, the most important question was about mechanisms. So, even once we identified exposure to deep sedation, we didn't really know why Latino patients were more likely to be exposed to deep sedation. We had some theories. So, for example, we think that implicit association may be part of the story, that nurses who titrate sedation orders may be more likely to perceive agitation in Latino patients. So the same level of movement or activity may be perceived differently for some patients compared to others. We thought that it may also have to do with family preferences. Perceptions about sedation that associate sedation with rest, sleeping, and comfort are more common in some groups than in others. And we also thought that it could be related to differences in language. So secondary language loss, even for people who are fluent bilinguals, secondary language loss is still actually pretty common in critical care because you are experiencing one of the most serious insults that your body can possibly experience. And so there are a lot of possible things that could be going on here, but we don't know which of them it is. So I think that what you can do, if you're interested in saying, okay, the other research has established that there is a disparity. So I don't want to do another study that shows that there is a disparity. Then you can go to the second stage of health disparities research, which is understanding the disparity, trying to identify mediators and moderators that may be linking the social determinant exposure to the clinically relevant outcome. And that's really important in public health, because in public health, we always eventually want to get to the third stage of health disparities research. And that is actually intervening on the causes of disparities in order to reduce them. In order to do that, you have to identify those mechanisms. So what I would recommend is first, write down a bullet point list of what's known, and then write down a bullet point list of what's not known, and try to pick something from that list of what's not known that you can answer. And in particular, maybe try to focus on these mediators and moderators, these mechanisms that are linking social determinant exposures to the outcome, because those are things that we can potentially target with an intervention design in the future. And in public health research, that's really valued.
Thank you so much for that. That was super, super helpful. Is that a question? No, that's a response. So another question that I think would be important to discuss is, when you're looking at these big data sets that have all these variables, it can be kind of overwhelming. In the process of developing a question, would you recommend looking at the data set and forming a question from a data set, or would you recommend thinking about what you want to study and trying to find data sets that match that question? Are both acceptable? What approach do you think would be better for a thesis project? And that question's for both of you.
Do you want to start, Dr. Satterstrom?
I mean, I'm happy to start. A lot of my work is not big data set. but I think some of the ideas apply. If for folks who do interview or observation-based work, I think it's really important that you have a strong mentor in that methodology, because you can get lost and overwhelmed so easily. And there's really an art and a craft in asking questions and making observations. And, to add to the previous questions, a lot of us can look at the same thing and get really different information. And for those of us who are trained to watch and observe and understand social interactions, you can sometimes watch things and see things that other people don't. So being an apprentice to someone else in our field is really important, because there's different ways of thinking, different assumptions, different logics that you approach data with. And having someone guide you is like, why this question is a strong question and why this question is a less strong question can save you so much time. In terms of trying to find data sets that fit questions versus, using data sets and figuring out what questions are interesting, in my opinion, those are both incredibly valid ways of approaching work. I think for those who have a passion for a topic, who came into this work because of personally meaningful things, I think finding some folks who kind of share those values and who have readily accessible data makes a lot of sense. I think for folks who are thinking about the training and getting methodological expertise and are perhaps less invested in, do we do this in TB, or do we do this in cancer, or do we do this in the US, or do we do this? You have more flexibility, which is both great and more difficult, because, the world is your oyster, like you can do anything. And so I think that, narrowing it down to something that is a great learning experience with a great mentor in some ways is almost more important than in using, the most interesting tool of the moment, or the question that is most in the news right now, because the training that I think you get from these programs, if done really well, is applicable across a lot of different areas.
What I would add to that, first of all, don't be scared away from doing qualitative theses. I've seen some really strong qualitative theses. It is possible. And what I've mostly seen in the School of Global Public Health are secondary analyses of existing qualitative data sets. And there are some real limitations to that. But as Dr. Satterstrom says, if you're working with a strong mentor, especially the mentor who helped produce that qualitative data set, then you're going to learn a lot from that process. And there's real demand for people who are trained in those methods. That said, I'm going to answer the quantitative side of the question because I'm the person with biostats training here, and I advise a lot of, most of the theses that I advise are in biostatistics or epidemiology, and they are mostly quantitative. I've seen it work in both directions, right? I've seen very strong theses come out from, for example, the student Kayleigh, who graduated from GPH 2 years ago now, I think. And she came to me and she was like, I'm really interested in determinants of mental health among refugees in refugee camps, very specific. And she got assigned to me because I did refugee work years and years ago, but I have no current work with refugees. And I was like, okay. And so she came into it. She had done work, first-person work with refugee populations. And she said, I really think that camp environments and that disordered camp environments and perceptions of crime in camp environments are going to have mental health consequences for refugees. And everybody forgets about this because they think that the trauma of the refugee experience of getting pushed out of their countries, all of the things that have the physical and mental and often sexual traumas that happen during that, everyone's so focused on that nobody's talking about how these refugee camp environments are hurting people. But I think that's what I've seen. And it took some doing to find an appropriate data set for her, but we found one. It happened that a former colleague of mine from Yale actually had produced a large data set that had measured a lot of stuff, including perceptions of camp environment, history of relocation, and she wrote a fantastic thesis that ended up getting published, right? So that can happen, but it required flexibility. You know, she came into it and was like, I really care about this topic, but I'm going to think creatively about how to operationalize the exposures and the conditions that I'm interested in for this population. I'm not going to be really rigid and say, like, it has to be the PHQ-9 or something, or the data have to be collected in this way. And so that can work. And the other thing that I've seen work well is people who come in and they say, you know, I'm really interested, say, in like adverse childhood experiences. We know a lot about adverse child experiences. There's only a few data sets that are longitudinal in a way that it's going to allow us to talk about long-term cardiovascular outcomes for people with adverse childhood experiences. And so I have to work with this data set. And then, you know, it's a little iterative. We're sort of like, all right, so, you know, you have some hypotheses here, but maybe we're going to come up with 3 candidate hypotheses and only one of them is going to be possible because we're only going to have those variables. So what I would say is identify a strong topic that you're passionate about and be willing to be a little bit flexible once you get to executing your analysis plan. You might have to change your analysis plan a few times before you get to something where you both have an interesting hypothesis and actually appropriate data with which to test it.
Awesome. Thank you guys both for those answers. And I just want to add, you know, I think it's very important to, if there's a topic that you're passionate about, follow that through. But if you notice, the commonality in both Dr. Satterstrom and Dr. Armstrong-Hough's answers were that you have to be a little bit flexible. So if you're really passionate about a topic, follow it through, but make sure that you're willing to be flexible enough that you're able to research that topic in a meaningful way, and you don't have to switch topics, because if you can only do one thing in that area, you're not going to do it at all. So keep in mind that idea of flexibility, because that was throughout both of their wonderful answers to that question. So we are wrapping up towards ending time. Are there any other questions that anyone would like to ask Dr. Satterstrom or Dr. Armstrong-Hough? All right, seeing no questions, I want to make sure that I will share my screen very quickly here. I want to make sure that we give you the QR code for the data sets that we have available for your thesis. You can scan this QR code. Sorry, it already took me out. There you go. You can scan this QR code, and this will give you data sets that are suggested that you might be able to consider for your thesis topics. And then I would also encourage you to attend some of our other lightning talks if you're able to. Everybody that we've had has a little bit different insight, does a little bit different work, and this is a great idea to see what's out there, what people are doing. Dr. Armstrong-Hough is the first person I've talked to that mentioned qualitative data, which is very important and also very interesting. So make sure that if there's other sessions that you're interested in, really try and attend those sessions and see what the possibilities for your thesis could be. So on that ending, we will go ahead and we will sign off. Thank you all so much for coming to the lightning talk. A special thank you to Dr. Armstrong-Hough and Dr. Satterstrom. Everyone have a great rest of your day.